Hello, good morning, everyone. My name is Kashif Maman. I'm a trauma and orthopedic consultant in Queen's Elizabeth Hospital, Birmingham, which is one of the major trauma center and tertiary care hospital in the Birmingham. Today, I'm going to talk about basic knee arthroscopy, how we can position the patient, and how we can systemically approach the knee through the scope. So the indications for the knee arthroscopy is either you can do the diagnostic arthroscopy, you can do the meniscal repair or meniscal resection for the removal of the loose bodies, and for the ACL and PCL reconstruction, synovial biopsy or synovectomy, chondral defect repair including microfracture, and osteochondritis dissecans treatment. So let's talk about the knee arthroscopy portals. So the basic portals are, or standard portals are, anterolateral portal and anteromedial portal, and then you have a posterior medial portal, superior medial portal, superior lateral portal, and posterior lateral portal. So let's talk about how to position the patient for the scope insertion. So patient should be under either spinal or general anesthesia, supine on the table with a tourniquet on, and a side support over the distal aspect of the thigh, so you can apply the varus or valgus force to insert the scope. So to approach inside knee to the for the lateral, you need to do the figure of four position, and to approach the knee on the medial side, you need to give a valgus strace. Make anterior, so palpate the soft spots over the knee, and then you can start with a anterolateral incision for the anterolateral portal. Some people use vertical incisions, some people use horizontal incisions, but I usually do the vertical incisions because that's more versatile and you can extend, and you can move your instruments superiorly and inferiorly easily in the vertical incision as compared to the horizontal incisions. But horizontal incision has advantages of increased mediolateral mobility of the instruments. Once you've done the incision over the anterolateral soft spot, you insert the trocar into the capsule, uh, or you can advance the blade into the capsule, then follow with the trocar. You need to do this first first incision into the flex position and insert the trocar into the flex position into the suprapatellar pouch. Once you touch the suprapatellar pouch, then you need to straighten the knee. So as I showed in the picture earlier, primary portals are anterolateral portal, which is a standard portal, and that is used as a viewing portal. And usually the anterolateral portal is done with a knee inflection, and you have to palpate the soft spot or the lateral aspect of the patellar tendon on the joint line. The next portal is the anteromedial portal, which is used primarily for the instrumentation, and again this portal is done in the flexed position of the knee. You have to palpate the soft spot over the medial aspect of the patellar tendon on the joint line. Then two other primary portals are superior medial portal, that is accessory portal, and superior lateral portal, that is another accessory portal. So secondary portals for the different type of the instrumentation and a repair work. You can do the posterior medial portal, you can use the posterior lateral portal, you can use transpatellar portal, proximal superior medial, and far medial and far lateral portals. So let's talk about how to do a diagnostic scope. So step one, with the knee fully once you inserted the scope in the flex position, then you have to extend the knee uh, in full extension. You can approach the suprapatellar pouch. Usually the loose body lies into the suprapatellar pouch. You can visualize the patellofemoral cartilage, and you can assess the patellofemoral tracking, and you can assess the trochlear groove. So this picture shows the patella on the top and trochlear groove on the bottom. Then once you have done the suprapatellar pouch, you can go either lateral gutter or medial gutter. For the lateral gutter, you have to see the popliteus tendon, and then lateral compartment. You have to see the anterior horn of the lateral meniscus, and you can see the body and posterior horn. Once you've done the lateral gutter, then you need to go into the medial gutter. So this is a picture showing a lateral compartment where you can see the femoral condyle on the top, you can see the tibial plateau on the bottom, and you can see the meniscus on the left side of the picture. Then you need to flex the knee after visualizing the gutters, and then you have to move to the medial compartment to see the medial meniscus, medial femoral cartilage, medial tibial plateau, intercondylar notch, and you have to see the ACL, PCL, and then you can approach the posterior medial corner. Posterior medial corner is best seen with a 70-degree scope placed through the notch. So this picture shows the scope is in an intercondylar notch, and you can pull the ACL with your instruments. Then subsequently put the knee in a figure of 4 position to finish in the lateral compartment, where you can see the lateral meniscus, popliteal hiatus, lateral femoral condyle cartilage, and lateral tibial plateau cartilage. So this picture shows the lateral compartment of the knee, where on the top you can see the femoral condyle. On the top, on the bottom you can see the tibial plateau, and on the right side you can see the body of the lateral meniscus. So let's talk about the complications. What are the complications of the diagnostic or knee scope? You can injure the articular cartilage while with your instruments, or while you are introducing your trocar, ham arthrosis, neurovascular injury, one of the most recognized complications. With the posterior medial portal, saphenous nerve can be injured, and with the posterior lateral portal, common peroneal nerve can be injured. Thank you very much for listening. I hope you have enjoyed the presentation. I love to be in Pakistan doing a face-to-face presentation, but unfortunately, because of the unforeseen circumstances, I have to do this recorded session. But I'm quite happy to take any questions via email. My email can be taken from the organizers. Thank you very much. Hope you will enjoy next session as well.